Good afternoon, good morning, welcome from wherever you're joining us in the world. And thank you for joining us for this webinar where we will look at Professor Ben Goldacre's review into how the efficient and safe use of health data for research and analysis can benefit patients and the healthcare sector. Today's session will be hosted by OII DPhil candidate and review co-author Jess Morley. A little housekeeping. We are fortunate to have a varied audience with a wide range of views, and we request that the opinions of others are respected in this space. For your awareness, this event is being recorded and will be posted on our website following the event. You can ask any question using the Q&A tab at any time, and these will be answered towards the end of the talk. Questions will be visible to all attendees and can be upvoted and commented upon, and we'll endeavour to follow up on any unanswered queries. Please allow me to introduce Jess Morley.
Hello, thank you everyone for joining us today to talk through the Goldacre review, Better, Broader, Safer Using Health Data for Research and Analysis. I am delighted today to be joined by the lead of the review, Professor Ben Goldacre. Ben barely needs any introduction, but just in case, Ben is a psychiatrist by training, has been a journalist and a best-selling author, and is now evidence-based medicine Bennett Professor of Evidence-Based Medicine and the Director of the Bennett Institute for Applied Data Science. And for his many, many sins, my friend and colleague. Welcome, Ben.
Hi.
So I will just give a little bit of background to the review, and then Ben, I'll hand it over to you to sort of talk through our main recommendations. But the aim really is today that we'll spend hopefully only about 20-25 minutes of us talking, and then mostly we'll take questions from participants, as I think that's what most people are most interested in. So the review was initially commissioned back in February of 2021. We spent about 6 months researching it. We interviewed well over 300 people. We did a number of different open focus groups with audiences from NHS Service Analysts through to data ethicists and privacy experts to try and gather everyone's views. We had over 100 written submissions, and then we eventually published the review on April the 7th in 3 different formats. There is a big long version, there's an executive summary version, and then there is a 25-page interim version. And last week, on the Monday of last week, the NHS data strategy was published, which includes the first part of the government's response to the review, which we were by and large very happy with. I'll talk about that a bit later. So Ben, over to you.
Hey, thanks, and thanks for having me. And hopefully we're coming to the end of the period of talking into an empty room alone in an attic. Actually, the one thing I should say is apologise if I seem a little slower than usual. I'm in an attic room and hot air rises, and this room is painfully hot. Also, secondly, looking at the pollen count, I can see this is the peak of the time of the year when I pretend that I don't have hay fever. So the review. We were tasked with finding ways to deliver better, broader and safer use of NHS data for both service improvement analytics and academic research. And more specifically, we were asked to identify the strategic or technical blockers to that kind of work and how they can be practically overcome. And as Jess said, we spoke to a tremendous number of people, and it really was an enormous privilege to be able to have such an enormously comprehensive bird's eye view from so many different perspectives in so many up-close discussions. So first of all, the context. It's been said so many times, but it bears repeating. NHS data is an exceptional and globally important resource. For 73 years, the NHS has been collecting detailed records and data on tens of millions of patients from a huge population, but also an ethnically diverse population. And because of that diversity, analytic outputs from NHS data can help save lives around the world. And it really is our global responsibility to make the best use of that data. And the combined GP records of the nation, as just one example, cover every person in the country. They go back many decades, and they capture some information about nearly every contact with health services, with huge detail on every prescription, every treatment, every referral, every diagnosis, and every blood test and its results. Now, that data set contains almost unfathomable depth and breadth. And that kind of data is at the core of all good work in healthcare. It's how researchers learn which treatments work best and for which patients. Data has driven the global response to the COVID pandemic, and it can help target work on the post-pandemic backlog. The life sciences sector can use that data to evaluate and refine medications or develop whole new classes of medtech. And by monitoring all activity and outcomes, NHS analysts can also find new opportunities to improve the quality, the safety, and the cost effectiveness of care across the whole health service. Now, it's important to reflect on what we have, but also what we're missing. So the nation has outstanding raw data, and we've also got world-class researchers. But raw data doesn't do great work on its own. Before it can be used effectively by researchers, that data needs to be curated, managed, cleaned, reshaped, and prepared by people. And then it needs to be made available in well-designed platforms, which can earn public trust through security and transparency, and which facilitate efficient sharing and reuse of prior work. And to date, the system has relied, for very understandable reasons, on lots of small data projects that don't join up, distributing large volumes of the same patient records to a vast number of uncounted and probably uncountable sites for different projects and different teams. And that duplicates implementation costs, it duplicates data preparation costs, the governance costs, and of course it duplicates the risks. It fosters monopolies around access to data and also to task, and it obstructs the transfer of ideas and analyses between settings. It also obliges the system to rely excessively on weaker security practices, such as pseudonymization, removing names and addresses from detailed health records, which I'll talk about in a little more detail in a moment, sometimes without acknowledging the shortcomings in pseudonymization. But it's also obliged us to build complex systems of governance, contracts, and trust that manage the security risks inherent in disseminating pseudonymized data by acting in a very slow and risk-averse manner. Now, that approach has arisen relatably from decades of getting by, but it can't ever scale to the kind of access that we need to be a world leader in data science. So I'm going to walk through phase by phase some of the problems that we uncovered in our discussions with 300 people, 100 written submissions, 8 focus groups, substantial desk research, and also detailed discussion with our senior stakeholder group. And then I'll walk through section by section as we go some of our core recommendations. First off, the risks of working with pseudonymized data. Now, managing a health service effectively or delivering high quality research at national scale requires that analysts have access to the most detailed information across the health records of near enough every individual in the country to do their good work. Now, that means a growing group of trusted analysts having access to every recorded detail of every medical event for almost every citizen, all the way back to birth. Now, here we have to square the circle. We have to work out how can we grant access for good work, whilst at the same time addressing the concerns of patients, professional groups, and campaigners who are rightly worried about patients' privacy being protected when very large volumes of data are accessed for analysis, for research, and for innovation. And this is the key challenge, how to square that circle, how to have your cake and eat it, how to grant access for good things whilst preventing access for bad things. Now, it's important that the system recognises the challenges in current approaches in order to have a pragmatic discussion about better working practices. To be clear, while I talk about the challenges in pseudonymization, I think the problem is not so much that we have looming privacy catastrophes. It's rather that by relying excessively on pseudonymization, the system has been anxious and slow, and so we've not been able to grant access to as many people as we'd like to. So, pseudonymization is the process of removing direct identifiers like name, address, date of birth before disseminating data to a wide number of people. Where it's combined with other organizational and technical controls, it can be somewhat helpful, but it's very common to find examples of the benefits of pseudonymization being overstated or pseudonymization being relied upon excessively. And the reality is that pseudonymization is easily reversed when you're working with very detailed data, such as NHS patient records. For example, knowing the approximate date range in which someone had a medical intervention, their approximate age, and their approximate location is often enough to re-identify somebody in a pseudonymized data set, and then, illegally, to see everything else in their record. And women are particularly vulnerable here because knowing the birth dates of somebody's children alongside their approximate age and their approximate location can often be enough to make a confident, unique match. And that's the kind of information that will often be known by a colleague or somebody at the school gate. Now, to be clear, this isn't to say that health data users are untrustworthy. But the system has to be resilient to untrustworthy users if we're going to broaden out the use of data to a wider number of innovative individuals. And it's also, to be clear, in context, very well documented that other large administrative national data sets are sometimes misused. So it's a real theoretical threat, re-identification, but we also know that large administrative and health data sets are sometimes misused. Now, the last thing that's important as context is that the risk of re-identification in pseudonymized data increases as the data set grows to cover a larger proportion of the total population, and also as data sets become more detailed. Now, that has important implications for all plans, for example, to gather large volumes of detailed data about the whole population, such as the GP Data for Planning and Research programme. And furthermore, when the number of people accessing a dataset grows, there's also an increase in the small risk of there being untrustworthy individuals amongst those with access. Now, that's important. Again, the vast majority of those accessing data are trustworthy and abide by the law, but it's important not to downplay risks, and it's sensible to have systems that are resilient and that require and that offer more in terms of reassurance to patients, the public, professional groups, and campaigners, than simply saying that we must ensure that individuals who access this data are all trustworthy. Now, because of the security shortcomings inherent in widespread dissemination of pseudonymized data, the system has additionally needed to rely on practices like getting lots of contracts in place, evaluating users to make sure they're trustworthy, and then administer that through complex regulatory frameworks and systems to decide who can have access to what data. Now, that additional set of safeguards brings two problems. Firstly, it creates very substantial anxiety for the individuals who are giving permission for each act of data dissemination. And we have to recognize that rules are implemented by human beings. And this makes the system cautious and slow, creating deep frustration and many, many abandoned projects for analysts, for researchers, and for innovators. Secondly, this approach of trust in contracts will always inherently struggle to scale to larger numbers of users, which is a key ambition for every minister and every senior leader in academia or government or the NHS who's ever talked about better use of data. So, pseudonymization alongside trust in contracts has not been sufficient on its own to reassure and to build out wider access. So, important context for the review is that on two previous occasions, the NHS and government have attempted to collect large volumes of GP data and then disseminate them out to multiple locations for work. The first of these in 2013 was the Care.Data programme, and the second of these was the GP Data for Planning and Research project in 2021. Both projects resulted in very large-scale concern from patients, professional groups, privacy campaigners, and others, and both resulted separately in very large numbers of patients opting out of their records ever being shared outside of their GP practice. Looks like around about 1.5 million people opting out on each of those two occasions. And that's now at the scale where it will undoubtedly compromise the usefulness of the data for some purposes. So this is the context. And it's clear that there is a way forward. In many other sectors, such as census work at ONS for 2 decades. Excuse me, I'm just going to make a horrible noise because my hay fever that I insist doesn't. Excuse me. Okay, so there's a clear path forward. In lots of other sectors, like working on census at the Office of National Statistics for 2 decades, data is not disseminated out to users. Instead, the analysts go to the data and work inside a secure platform called a trusted research environment. And our core recommendation is that the NHS should move to adopt this, that all data by default should be present only in a TRE. And that's why it's fantastic to see that the GP Data for Planning and Research programme was put on hold in the summer of last year with a clear recommendation and a clear commitment to patients and to GPs that it would only go ahead when the NHS had built a trusted research environment and that the data would only ever be accessible through those settings. So, if we could just zip up the first slide on trusted research environments, our practical recommendations, and to be clear, in the whole document, I think there are, well over 100 recommendations. We've boiled them down to 30 summary recommendations. Let me talk you through the core ones on platforms and security. Firstly, we can't earn trust through communications and public engagement alone. We need to build trust by taking concrete action on privacy and transparency. Secondly, We need to accept, confront, and openly discuss the shortcomings of pseudonymization and trust as techniques to manage patient privacy. Thirdly, we need to build a small number of secure analytics platforms, shared, trusted research environments, and make the use of these the norm. So instead of disseminating data out, keep the data in one place. And this has huge benefits. First of all, it's much more secure for patient privacy, much more transparent. But it also, as per recommendation number 6, an opportunity to drive modern, efficient, open, collaborative approaches to data science. Because where everybody's working on the data in the same environments, using the same tools, that means that they can share each other's approach to data curation, data analytics, and data visualization. Recommendation number 4, we can use the enhanced privacy protections of TREs to create new, faster access rules and processes for people using NHS data. We can also ensure that all TREs publish logs of all activity in order to build public trust. And then number 5, at the moment, there are very large volumes of data being disseminated around the system. Their destination is unclear. It is important at the very least to map these and ideally to shut them down wherever possible as soon as trusted research environments for GP data meet all reasonable user needs. And we flag GP data in particular because this is the only part of the universe of NHS data where national data on 58 million patients is available in one single harmonized data set and is also extremely granular. It's much more detailed than anything you'd see in any other data set like HES, which has only very sparse data on hospital events. So that's trusted research environments and privacy. I'll talk now very briefly about some other aspects of our work. First of all, I'd like to talk about modern open working methods for NHS data analysis. Now, this is a stretch. One of the great challenges of this kind of work, in particular talking to government and the NHS, is that the reality of working with data is that you're writing code. You're engaged in complex technical work. And I think across all forms of technical work, but in particular new forms of technical work, government typically struggles to find expertise, especially in its own senior leadership community. Now, raw data, like NHS patient records, is prepared, analysed and visualised by writing code that issues instructions to computers. And that data preparation and analysis work is complex and technical work. Furthermore, it's not done by isolated individuals. It's done in huge arcing chains of mutual interdependency, writing complex code across multiple teams and organisations. Now, there are well-established methods for imposing systematic order on that kind of challenging complexity in other settings. People develop code interactively and collaboratively in industry standard systems that allow teams to track their code, annotate it, attribute changes. People write adequate technical documentation that syncs alongside their code for all subsequent users or viewers. And also people take recurring tasks and turn them into functions that are regularly reused, and so on. Now, at present, too much work with NHS data at all steps of curation and analysis in all sectors, whether it's service analytics or academia, is done behind closed doors. And that's often driven by thoughtless defaults rather than any strong motivated decision to support closed working. But we were given throughout the review multiple very clear examples of situations where code and methods used to generate insights for service analytics or for research were actively withheld in ways that clearly held back replication, obstructed critical review, obstructed quality assurance, obstructed validation, but prevented re-implementation, prevented reuse, and prevented improvement of the work. And furthermore, where they seem to serve no clear strategic national benefit from withholding the code from the wider community. Now, this is a challenge that's well recognised in other settings, as I said. In adjacent academic specialties, such as physics or structural biology or genomics, there is a long and very familiar history of people working in the open, sharing their code as they go. Furthermore, in other parts of government, there's been very good progress. So the Office of National Statistics and the Government Digital Service have developed over recent years a set of best practice principles for modern, open, collaborative working with data. And actually, I'm very glad that they have. It's been branded as something called reproducible analytical pipelines. And because it's been branded like this, it's not just us saying, this is a really important, useful way of working. It means that there's a clear set of training materials and working practices that we can point to. So RAP, as it is known, sounds a bit groovy, uncle. RAP, reproducible analytical pipelines, is a clear set of design principles. It talks about minimizing manual steps such as copy paste. It talks about the use of open source software for data management. It requires that code is open for review and reuse, with all code shared openly through standard open file sharing, code sharing platforms like GitHub, making sure that your code is well commented, and so on. And so our key recommendations here are all around ensuring that this is adopted. Now, there's lots in the review about some of the barriers to open working, which I'd be happy to talk about later, and which I think are a good human overview of some of the cultural challenges. But just going down some of our core recommendations. First up, promote and resource reproducible analytical pathways as the minimum standard for academic and NHS data analysis. Now, in practical terms, that means ensuring that all code for data curation and analysis paid for by the state through academic funders and NHS procurement is shared openly with appropriate technical documentation to all data users. It means recognising software development as a central feature of all good work with data, and that means universities working differently. For example, working more closely with research software engineers, providing appropriate training and capacity building for those kinds of much needed and very overlooked members of the workforce. So next, 10, bridge the gap between health research and software development. It's a peculiar paradox that analysis is done by writing code. If you're writing code, you really want to have people whose life's work is becoming really, really good at writing code. So train academic researchers and NHS analysts in contemporary computational data science techniques, but also we need to take people with 20 years worth of software developer and data science skills and give them onboarding training so that they can come in to work on NHS data in an epidemiology setting with in-person training, online training, and online resources openly available. And then lastly, you can see in recommendation 11, a hint of some of the conversations and some of the misunderstandings that happen in the background. It's really important to reflect that open code is very different to open data. So I think personally, it's absolutely reasonable for the NHS to sometimes do quick looks, to look discreetly at variation in clinical activity or outcomes between different hospitals or different GP practices. There's room for discussion about when that is and isn't the right way to do things, but it's very separate to sharing your code. You can share your code without sharing your data. Next, again, hard, deep, and technical work, data curation. Now, the ABPI told us that they estimate that about 80% of all work on an analysis project using NHS data is spent on data preparation. And they previously recommended that 80% of all national resource deployed on data science in the NHS by the state should therefore be spent on optimizing data curation. And I very strongly agree. The team spoke to a very large number of coalface NHS data analysts and researchers during the course of the review, and they overwhelmingly expressed deep frustration at the scale of duplicated effort in this space. Now, we don't have time in this session to go through any great detail, but just as a window into the challenges, electronic health records in the NHS are not created for research or analytics. They're administrative data sets and they're created for a specific purpose. They're there really as a kind of aide memoir for clinicians to keep track of decisions for later review with their patients in order to make informed decisions about care. They're not there for research and analysis. And if you want to create, for example, a data set that says for each person in a given area or nationally, is this a child with asthma? There isn't a place where you can just do a SQL query unless you've got access to God's giant SQL database in the sky. Instead, you've got to build those variables from raw data on things like prescriptions, referrals, and diagnostic codes, each of which has their shortcomings. So, for example, there'll be many children in GP data who are registered, who have had a diagnosis of childhood asthma, but have only ever had one blue and brown inhaler and then never had anything ever again. Would you say that they still have asthma 1 year later, 3 years later? That's for you to decide when you're curating the data, and your answer will probably be different for different kinds of analyses in which it's important to know whether or not you have a child with asthma. So, after that brief window into the challenges and complexities, our recommendations on data curation, which are very closely related to our recommendations on open working. First of all, we've got to stop doing data curation differently every time to variable and unseen standards, duplicatively in every team, every data center, and every project. We've got to recognize data curation as a substantial, pivotal, core, foundational national challenge. And it's a high status technical challenge all on its own. It is not about doing an analysis that produces a graph or an academic research paper in an academic journal. This is about focusing on the intermediate foundational work that is necessary to support all individual analyses using NHS data. 13, we're going to meet this challenge with systematic work on curation, devoted teams, shared working practices, shared tools, and shared documentation. 14, we've got to use TREs as an opportunity to impose some light touch standards on how commonly used data sets are stored and curated into analysis-ready tables. And then lastly, we've got to work on knowledge management, which is one of the great challenges in this space. Create an open online library for NHS data curation code, validity checks, and documentation. So that's the hardcore stuff. From here, it's plain sailing, and I'll speed up a little. First up, there's a chapter on Modernizing NHS Service Analytics. Now, this is absolutely pivotal, and there is, in some respects, a bit of a lost tribe. In other parts of government, we have the Government Economic Service, the Government Statistical Service, and so on. We have continuing professional development and training for people who are doing practical day-to-day data analysis in order to monitor the quality, safety, and efficiency in services, to find opportunities to improve, to model demand, and so on. In Government Economic Service and Government Statistical Service, there's training. There are clear job descriptions. There are career pathways. There are parallel systems of line management. There's online resources and training, and so on. Now, interestingly, and it is a cultural anomaly, the NHS Analyst Service has been overlooked. So there are many, many thousands of people who are currently working as data analysts in the NHS. They are dispersed in silos across a couple of hundred hospitals, a couple of hundred CCGs, half a dozen commissioning support units, and increasingly primary care networks, federations, sometimes individual practices, CCGs, and also integrated care systems. There is a culture of people working in silos with very little culture of sharing of code, of methods. There's no career pathway, no training, no structures, no parallel system of line management. Salaries are very unrealistically low for data science, which is one of the most hot tickets in the job market today. So our recommendations in this space are, first of all, essentially to learn the lessons of the Government Economic Service and Government Statistical Service. So ahead of profession, create an NHS Analyst Service, have clear job descriptions tied to technical skills, progression opportunities where you can become a senior analyst rather than only being able to go up by stopping doing the technical work and becoming a manager, and realistic salaries where expensive data science skills are needed. Embrace modern open working methods and commit to reproducible analytical pipelines, both in your work and also in your training. Create an open college for NHS analysts where there's a curriculum for initial training and CPD, continuing professional development, tied to job descriptions, and making sure that all that training content is shared openly and online to all, covering a range of skills and roles from deep technical data science up to data communication. Recognize the value of knowledge management. So create and maintain a curated library of NHS analytic code and methods and work with adequate technical documentation for common and rare analytics tasks, and help spread knowledge and examples of best practice across the community, and then seek expert help from academia and industry, but ensure that everything that's procured is open code. So procure your code and your curation work on a buyout basis. And then lastly, train senior non-analysts and leaders in how to become good customers of data teams. Last section, information governance. Now, overwhelmingly, we were told by researchers and analysts of their deep frustration, in many cases rage, in many cases deep sadness at how difficult and slow it was to get access to data. Increasingly, I think people recognize that that's because of the challenges inherent in disseminating data that's been pseudonymized. Our recommendations in this space are clear, and I think it'll be clear to you from what we said already what they're going to be. First of all, of course, we should rationalize approvals, create one map of all approval processes, require all relevant organizations to amend it until they all agree it's accurate, deduplicate the work, and so on. But secondly, we need to make it easier for people to access data as per the TRE section above. By using the privacy benefits of TREs, we can say, if you're accessing data through a TRE, you do not have to go through the same difficult steps that you have to go through to download data. So essentially create a fast track for people working in more secure ways. We've got to be clear that doesn't address the ethical issues, but it does address the information governance and privacy issues. Then finally, having used TREs to address these privacy challenges, you are then free to have very focused conversations about the big ticket items on the ethical and the political front that have vexed people for a long time, and that there has been a tendency to dance around. So firstly, before we adopt TREs, any conversation about the use of commercial data, about the commercial use of NHS data for innovation, confuses two issues. It confuses, does a commercial company have access to your data to breach your privacy, which is one issue. It conflates that with, what do we think about commercial companies being able to profit and innovate in NHS data at all? Now, I don't have particularly strong views on that, but when TREs have allowed us to disentangle those two questions, that's the time to go to the public, possibly with citizens' juries, and have detailed discussions about what we think around that. The second issue that has been danced around for too long is the need for clear rules around NHS patient records in performance management of NHS organisations. There is a bit of a dance, and this is an open public session, so I will be super polite and diplomatic, but there is a bit of a dance where each NHS organisation or part of government wants access to data about everybody else so that they can see what they're doing, but doesn't want anybody else to have access to their own data in order to monitor what they're doing. And so I think we need to come up with better ways of managing those complicated conversations, and there's a big chunk in the review on that. And then lastly, we need to address the challenge of 160 trusts and 6,500 GPs all acting as separate data controllers. It's 1:33. I've rambled on because I'm not speaking as fast as usual because of my hay fever that I'm in denial about. Jess, if you could just flip up the final strategic slides, because I think these are important. What we've recommended are some quite major changes. Jess is going to talk a little about the NHS data strategy, which is just one part of where we're hoping for traction in the system, but it has been fantastic to see such a positive result from them. But there are some big overarching strategic issues here. First of all, we've got to get more people with technical skills in government and the NHS managing complex technical problems. That's not just getting senior leaders with history and PPE degrees to familiarise themselves superficially with data science, although that is useful. We also need to create senior strategic leadership roles for data architects, data scientists, and developers. We may need to offer leadership training to people in existing technical roles with existing technical skills. 27, we need to build impatiently but incrementally. So new ways of working are overdue, but we can't do it overnight. In particular, we need to build skills and prove the value of modern, open, collaborative approaches to data science in parallel to maintaining old services and old teams. And so on that, we think the best way is to identify a range of data pioneer groups, find perhaps 3 integrated care system analyst teams, 3 national quality improvement registry or audit teams, 3 academic birth cohort or electronic health record analytic teams, and 3 national EHR service analyst teams. Select them competitively and work closely with them to prove out new, modern, open, collaborative ways of working with reproducible analytical pipelines in a TRE. And then finally, build TRE capacity by taking a hands-on approach to the components of work common to all TREs. So we've got to avoid buying black box platforms from which little can be learned, and instead build out the components of TREs, build out really a science and a commons of knowledge in how we build TREs. So that's an overview of the review. I'm going to hand over to Jess, who's going to talk a little about the response so far from the NHS.
Yeah, I'm going to say this really quickly. By the way, I have no idea whether people can see me or not. I can see myself, but apparently maybe other people cannot see me. But if you can't see me, then that's actually better for you. So very, very quickly, because I think it's much better if we just get onto questions, but I'll just run through this so Ben has a chance to have a sip of water. So the NHS data strategy is the first part of the government's response to our review. by and large, we really like it. It came out last Monday. Oh, I am flicking on and off. How very strange. It came out last Monday. It sort of, if we take that there are 5 key areas of our recommendations, it does pick up on 3. So very, very, very happy to see that it says that it's going to take forward implementing secure data environments as the default across the NHS. It goes into significant amounts of detail about what those will look like, mostly picking up on the sort of design specifications we gave in the review. It says that it will simplify the IG framework, creating fit for purpose rules around different types of data, including pseudonymized data. That was a really big one that we wanted to make sure that people were clear about the differences between anonymized, pseudonymized, and identifiable data. There's a whole bunch of stuff in there that's really great as well about participation, and which we didn't really talk about in this session because it's not tends to be our area of focus, but there's some really good things in there. And lastly, it has this wonderful phrase which made me so happy when I saw it. Public services are built with public money, and so the code they are based on should be made available across the health and care system, and those working with it to reuse and build on. So by and large, it picked up on our recommendations with regards to trusted research environments, open working, and information governance. It touches less on the stuff to do with modernizing NHS data analytics, and slightly less as well on data curation, but we are happy and confident that those things will be picked up going forward. So I'm going to stop my screen now and jump onto questions. And right, so I'm going to go with the ones that are at the top first. Amadeus, I can see that you have asked many questions. Just in the interest of fairness, I will probably only pick 1 or 2, but do feel free to email either myself or Ben after the session if you have more questions. So I'll just pick up this question first. I've heard we have great raw data quite a few times, but as you point out, the fragmented nature of, for example, EPR systems means we have really poor standardization of data, and there's a lot of missing data, poorly coded data. So even though the question is essentially data curation will help with some of this, but do we think at the source we also need better data capture to make sure clinical data is more accurate and clear when it is entered?
So there's quite a lot on this actually towards the end of the section on data curation and around clinical informatics. I think first off, the NHS GP data set really is the jewel in the crown because it's a consistent format across the whole system. There have been a lot of people who've spent their time on the planet trying to harmonize all electronic health records data in all hospital systems. I personally think that's wildly unrealistic. I think data curation is the answer, not just to harmonizing data for service analytics, but also data curation is the answer to making data interoperable between systems for direct care. And I say that with something of a heavy heart. I would like to live in a world in which you could assert standard data models, but I think a lot of the innovation in electronic health record systems naturally entails modifying the data schemas and so on. So I think it will always be an enormous challenge. So I think data curation is an important part of that. And I'm really keen that we see more focused work as part of data curation on feedback to the clinical coalface. So in the 1980s and 90s, when primary care was first being computerized, and that was a long time ago and a great triumph of British medicine, actually, 96% of all GP practices were fully computerized by 1996. But when that was being done, there was a workforce run by Primis out of the University of Nottingham, and they had hundreds of staff who would go out to every GP practice to help them clean up their data. So they'd say, you're prescribing a lot of trimethoprim, which is the antibiotic only really used for urinary tract infections, but you don't seem to be coding anyone with urinary tract infections. Can I explain how the coding system works, why it's important? Let me give you some audit and feedback data that is useful to you, that uses that data. And I think we need to have a modern equivalent of that. I don't think it needs to necessarily be a manual labour workforce, although there may be a component of that. But I think we need to attend to that much more closely. So I agree overall that improving data quality is key. My worry is most of the work that I see in this space comes under the heading, and this is a common malaise in this space, of nirvana manana. People saying, oh, well, there's no, the only thing we can try and do is just homopify everything, which isn't the right answer anyway. Or, create an open source electronic health record system and make every hospital use it. I think all of those kind of giant data harmonization challenges and data quality improvement challenges are just too big. I think we need to work with what we have incrementally. And when we do that, we'll learn a lot about the next steps.
Okay, fab. Thank you, Ben. So the next question is, do you have any thoughts on how we can resolve some of the challenges with pseudonymized data that is essentially anonymous in practice, but personal data in law? So I think this is getting at the section that we have about clarifying the different definitions.
Yeah, so this is a real problem, and it's a problem that cuts in both directions. I think there's a lot of nervousness around the system generally in talking too much and too concretely about the shortcomings in pseudonymization, because an enormous amount of current work that is safe is actually built on having to play around with the grey areas, not play around with, but it's built in the grey areas of definitions in law. And I think that's one of the very unhelpful features of the legal and regulatory framework in this space, is that it has been built in part in the absence of any clear thinking around pseudonymized data, its strengths and weaknesses, and also the context in which data is used. That is acknowledged and discussed in some parts of the system, but not in others. And it's talked around too much in legislation. So I think it is a real problem, both in that it permits things that aren't very helpful and also obstructs things that are helpful and safe.
Great. And so this is a very specific question, but I think you can probably generalize it a little bit. So would implementing our recommendations have an impact on the MHRA CPRD? Is this one of the bulk flows of GP data that should be shut down, or should it evolve to become one of the TREs?
I've been hoping that MHRA will produce a trusted research environment around CPRD for many, many years. I have had concerns about them allowing people to download large amounts of data for many, many years. And I very much hope that that practice will stop, not just at CPRD, but everywhere.
Yeah.
I mean, I think one of the bigger challenges actually is CPRD is the very large pseudonymized bulk data download service with hundreds of customers downloading the data, but it's the one that we know about. There are many, many other similar services which are really barely known to government or the NHS at all, and that reflects some of the challenges that we also talk about in the review, whereby there are 6,500 individual data controllers in individual GP practices. There are 160 data controllers in 160 trusts, each of them making autonomous decisions about whether to share and not share, and that creates all kinds of problems. First of all, it makes no sense at all to expect 6,500 GP practices, partners, practice managers to separately evaluate the privacy offer and the patient benefit of different data sharing projects. That's ridiculous, and it is very foreseeable that you will get, as a consequence of that structural decision, many, many good, sensible data extracts, including those with consent, like UK Biobank, being obstructed by some GP practices. In many cases, I'm sure, just because they say, I'm not an expert and I don't have time to evaluate this. But at the same time, it's clear that there are many practices which are signing up for data downloads, which I feel, were they to be more clearly explained to the people making those decisions, they may make different choices about whether or not to sign those contracts. And that's why we recommend not so much a review of data controllership, which is one of the questions from Chris Carrigan in the chat, but rather consideration of whether to make decision-making trusts. So whatever subset of 160 hospitals and 6,500 GPs might say, well, you know, there is one organization, I'm just going to trust them to make sensible decisions on my behalf about this data. And that might reduce some of the chaos that we see at the moment.
Okay, fab. So a couple of quick things that are in the chat. First of all, someone has, and I thank you for reminding me, because I totally forgot to say that there was the launch of the RAP strategy yesterday. So the cross-government RAP strategy, we were, yes, definitely, we've read it, super happy to see it, especially the fact that it mentions research software engineers in there and their individual role, and the link between better use of RAP and better care of citizens. We all thought it was fantastic. So the other sort of quick one, which I think the simple answer to this is yes, but they just don't get enough recognition at the moment, was we call out in the strategy and in the documents that we need to recognize software devs as central to good data work. And this person is asking, what about recognizing data stewardship and management? And I think we would agree, yes, they are essential, but they already have a fairly well recognized role, whereas data software devs maybe do not so much.
I think that's right. I do think, though, it's one of the great shortcomings of the way that funders in particular have approached this kind of work. There has been an excessive focus and value on the single research paper output that comes from working with electronic health record data, or indeed research data that's being collected as raw data. And actually, the intermediate components of the work necessary to deliver a single research paper output are often more important, more productive, involve as much, if not more, creative, intellectual and academic innovative thinking, and are probably actually more interesting now than just cranking the handle to turn out another logistic regression analysis for another observational epidemiology paper. And I think there's been a real strategic shortfall in UKRI and NIHR and MRC in particular, of recognizing the value of that intermediate work, and also recognizing the need for independent, high status career paths around data curation, secure analytics and platform science. And so in the review, we recommend things like fellowships funding for software projects and open code projects and foundational methods in data curation, in secure analytics, secure output checking, privacy preservation, and so on. And I think that's really crucial. And actually, as Jess says, data stewardship is one of the small areas where we have seen a little forward plot movement. So over the last 10 years, for example, some of the birth cohorts, which are manual data collection projects, have moved from being a closed shop where they collect the data, they store the data, and they do the research in the data, and started opening up their platforms and their data for other people to use, but only because they were funded through open competitive funding from NHR, UKRI and ESRC and MRC to do that. And I think we need to see more of that around platforms, curation and secure analytics.
Yeah, I could definitely agree. I think this question sort of picks up on that theme about where we would like to see more funding. So this person has asked, how do you think about other privacy enhancing technologies, including differential privacy or federated learning, to either accompany or augment the TRE solution? And I know that when we went to speak to the select committee, you were saying that it's very difficult for us to answer those questions directly because nobody has really funded the sort of practical and applied research that would enable us to genuinely answer those questions.
That's right. Yeah. I mean, differential privacy is the more sort of contemporary highfalutin end of privacy management. I've not seen any applied practical work of that in health ever. TREs are here. They work really well. They reduce cost and complexity by reducing duplication of effort on data housing, on data management, on data curation, on data access, on the computational environment in which data is stored. They remove duplication of risk. They remove duplication of governance. They're the right place to start. All that other stuff is also great, but they're the sorts of things that I think you would use principally to augment security in a TRE. And in particular, things like data minimization. I mean, it was remarkable actually to reflect when being asked by MPs on the select committee, how good is data minimization at protecting privacy, to have to say nobody knows, to have to say nobody has ever done simple k-anonymity profiling or re-identification threat modeling on data at different levels of data minimization. That is, albeit a technical story, it is a remarkable indictment of how far behind all of that foundational work in health data research has been allowed to fall. And I think it's testament to the fact that we need a new broom, we need a new focus, and probably new institutions focused on the foundational work in health data science around platforms, curation and secure analytics that are focused only on that. Because one of the lessons of working with government is you need people to have quite a singular focus, otherwise they get distracted, as I suppose we all do. Look at this messy attic room, for example.
Thank you, Ben. So I think we were going to try and end at 5:02 for give everyone who, like us, has another meeting to go to straight at 2 a slight chance for a bio break. So I'm going to ask you 2 more questions, and then there's a bunch of questions about PPIE which I can answer if you need to run. So question first is, which I think is a really interesting one. Do we have any measures of success which we can use to evaluate the effect of our report recommendations? For instance, the time it takes for a researcher to get access to the data to undertake their research now and in the future.
I think that's a really good one. I'm not sure I'd put us necessarily in the category of people who have so many levers that I put numbers on our success criteria. And I must say, by the way, just in terms of context, it's very challenging to do this kind of work. You know, government and the NHS is complex. In particular, it's complex because there are so many people with good intentions, with such a long history of trying to get by in a complex technical space like this. There really are there are no or very few bad actors in this space. There are a lot of legacy projects. There are a lot of unhelpful ways of working that are often insular, but for very relatable reasons, because people have just been trying to get by. And in the context of all of that cultural complexity, I'm staggered and full of admiration for how far we've come with some of the changes, in particular in the data strategy, where we've gone from, when we first started, so many conversations around the system with people saying, I'm really not sure you're right about pseudonymized data. That can't be right. To now a full and I think correct and sensible embrace of the need to work with TREs, the need to engage with those as a foreground activity, TREs as the answer to replace dissemination for both more secure work and for more efficient work. And so I think, I don't know if it was implicit in the sense of measuring progress, if there was a sort of an implicit sense of will good things happen or not. And I am staggered and delighted by the early indicators of pace and change in the system. I think, however, the real challenge now is implementation. If you say you want TREs, that's great. Then you've got to get them delivered. There are a lot of players in this space who have taken a lot of resource to deliver TREs and similar things like federation through TREs, where we were told by senior leaders across the system on many occasions, there was an abiding sense that money went out the door for that task, but very little trace of delivery. I think the real challenge now is operationalizing it, is in delivery, but I think we can do it.
Yes, I think we can do it too. So final question, I think, and then what I'm going to do is I'll put up a slide that has our generic team email address, my email address, and both mine and Ben's Twitter. So for any of the questions that don't get answered, we can take them to an asynchronous method of communicating. So the last most popular question is, would you agree that there's also urgent work needed to clarify what good PPIE is at a national level and at a TRE level? This felt like an admission from the review, and it needs to sit alongside what a good TRE looks like.
Yes.
So I think our answer is yes.
Yeah, I mean, we talk about PPIE a little. I think, like a lot of people, and this is a very delicate area, there's a bit of a worry around perhaps more performative types of PPIE. And I think the thing that's disappointing is to see so many duplicative, quite superficial projects around PPIE. For some of the core issues, and I think this is where the Wellcome project, understanding patient data, was so powerful. For the recurring challenges in PPIE, it's better to have single robust projects nationally rather than a superficial attempt on 200 separate occasions to ask people, do you think it's great that data is used by researchers for public good? So I think that's my main concern. I mean, Jess, you're the world expert on PPIE in this setting.
Yes, I do agree. We need better standards of what it looks like, and we do in fact make that recommendation that you should make standardized good looks of what PPIE. I think and we do in fact list a set of criteria out as what does that look like. I think our main takeaway is that you probably shouldn't do PPIE that is just going and asking people in a survey repeatedly over and over again, do you trust X company, do you trust Y company to look after your data, and then do that repeatedly in a closed fashion and then do nothing about it. And secondly, it's much better to take PPIE in a discursive manner where people are actually given the chance to learn and change their opinion and then actually act on those findings. But I could anyway wax lyrical about that topic for hours, but we are out of time. So thank you so much everyone for joining us. This is the screen. I'm going to leave it up for the next couple of minutes just until we end. But thank you very much for everyone for taking part. Thank you, Ben, so much for your time. And I hope everyone enjoys the rest of the day. And please do get in touch if there was any questions that we didn't manage to ask. And if you do want to watch this back, just a reminder that it will be recorded and it will be up on the OII's website normally in a couple of days. And thank you very much again. Bye.
Cheers all. Thanks for coming. Thanks, Jess.